Welcome back. Today, we are taking those dense, often intimidating CPT evaluation and management guidelines and turning them into a clear, actionable playbook. We're going to decode the rules that govern your documentation, building from the basic foundations all the way up to the highly nuanced world of nursing facility services. Let's get right into it.
Let's kick things off with a hard truth. When it comes to E&M coding, inaccurate documentation is a massive double-edged sword. Undercoding, you're literally leaving your well-deserved reimbursement on the table. Overcoding, you're leaving the door wide open for a devastating compliance audit. Proper documentation isn't just paperwork, it is your shield and the absolute key to making sure you are compensated fairly for your work.
Here is our roadmap for this explainer. We'll start with the new E&M foundation, break down medical decision-making, and unpack the time-based rules. Then we'll hit split or shared visits, dive deep into nursing facility services, and wrap up with compliance and audit readiness. Let's get to it.
Part 1. The new EM Foundation, featuring two completely distinct paths to code selection.
The modernized AMA guidelines actually did us a huge favor. They beautifully simplified how we select codes. You remember the old days, right? Counting every single element of a patient's history and physical exam? Well, those days are gone. Now you simply choose between two distinct pathways, medical decision-making on one side or total time spent on the date of service on the other. It really all comes down to complexity or time.
Moving to Part 2, Medical Decision-Making, or MDM. This is really the core of complex care.
If you decide to go down the MDM pathway, your code is driven entirely by cognitive work. This breaks down into three crucial elements. Number 1, the number and complexity of the problems you're actively addressing. Number 2, the amount and complexity of the data you have to review and analyze. We're talking labs, imaging, or independent histories. And number 3, the risk of complications or morbidity that's tied directly to your patient management decisions.
So how do we put these three pieces together? Honestly, just think of it as a best 2 out of 3 system. To hit a specific level of MDM, whether that's low, moderate, or high, you have to meet or exceed the requirements for at least 2 of those 3 elements we just talked about. So say you have a high number of problems and a high risk of complications, but you only looked at a minimal amount of data. You still score a high MDM. 2 out of 3. Simple as that.
Okay, Part 3, Time-Based Coding Rules. This is all about capturing the complete encounter.
If you opt for the time pathway instead of MDM, you have to know exactly what counts. And the rule is, it's the total time spent on the exact same calendar date of the encounter. And listen, this is a real game changer, because it's not just face-to-face bedside time anymore. It includes preparing to see the patient, counseling them, ordering tests, and yes, literally the time you spend documenting in the EHR. As long as it happens on that same calendar day and you personally perform the work, it counts.
Now hold on, because there is one major exception you absolutely need to be aware of. Time cannot, I repeat cannot, be used to select emergency department service codes. Why? Because ED services are typically provided on a highly variable intensity basis. You're constantly bouncing between multiple patients over an extended period. Because of that chaotic environment, you have to rely entirely on medical decision-making for ED codes. Time is completely off the table here.
All right, Part 4, Split or Shared Visits. Let's look at team-based care in facility settings.
In hospitals and facilities, patient care is usually a team effort, right? A split or shared visit is simply an E&M visit performed jointly by a physician and a non-physician practitioner, or NPP. Think nurse practitioners or physician assistants. Crucially, they have to be in the same practice group. And a really important note here, split and shared visit rules apply specifically to facility settings, like hospitals and nursing facilities. You do not use these rules in a standard office setting.
When you're billing a split or shared visit based on time, greater than 50% is your golden rule. The entire service gets billed under the NPI of the provider who spends the majority, so more than half of the total time. But remember, both providers have to clearly document their distinct contributions to prove exactly who performed that substantive portion. No generic copy-pasting allowed.
Now for the main event. Let's bring all these foundational rules together and apply them to Part 5, Nursing Facilities Services. We're talking CPT codes 99304 through 99318, covering skilled nursing, intermediate care, and long-term care facilities.
Let's walk through what a patient's actual journey looks like in a skilled nursing facility, because the care follows a very distinct timeline, and CPT gives us specific code families for each phase. Right at the start, you have the initial comprehensive care on admission. Then, you transition into routine subsequent care visits for ongoing monitoring over the following days, weeks, or even months, and eventually discharge management when they're finally ready to leave. Oh, and for your long-term residents, there's also a specific annual assessment code, 99318.
Let's break down the initial nursing facility care codes, 9934, 305, and 306. You select these based on either your MDM level or minimum time thresholds on the date of the encounter. Take a look at the high-level initial visit, 99306. That requires 45 minutes of total time or high MDM. Now here is an absolutely critical compliance rule you cannot miss. Under CMS regulations, the mandatory initial comprehensive visit in a SNF must be performed personally by a physician. Even if an NPP or another qualified healthcare professional does prior assessments, the physician has to do that mandated initial visit.
Once that initial visit is done and the patient is established, you move to subsequent care. These codes scale up nicely based on complexity or total bedside and unit time. 99307 requires 10 minutes for straightforward MDM, 99308 takes 15 minutes, 99309 is 30 minutes for moderate, and 99310 hits 45 minutes for high MDM. But contrast that with discharge management, codes 99315 and 99316. These are strictly based on cumulative time on the actual date of discharge, face-to-face and non-face-to-face. 30 minutes or less, total? Use 99315. More than 30 minutes? That's 99316. And like I mentioned before, if you're doing an annual nursing facility assessment for a long-term resident, that's CPT 99318, requiring low to moderate MDM or 30 minutes of time.
Finally, Part 6, Compliance and Audit Readiness. Let's talk about protecting your practice.
Look, knowing the codes is only half the battle, right? Keeping the auditors happy is the rest of the job. Here is your audit-proofing checklist for nursing facilities. Step 1, clearly document your MDM rationale. You need to actually show your math with things like differential diagnoses and risk assessments. Step 2, if you're coding by time, explicitly state your total time and make sure those pre- and post-visit activities are recorded. Step 3, watch out for NPP signature compliance in SNF settings. Missing physician co-signatures where mandated are a massive red flag. And Step 4, for discharges, auditors are actively looking for the mandatory elements: a final exam, a discharge summary, medication reconciliation, and post-discharge orders. And please, don't trigger an automatic audit by billing initial care codes for a patient who was readmitted within 30 days if you never formally discharged them in the first place.
So I'm going to leave you with this question to ponder. If an auditor looked at your notes today, would they see the true, undeniable intensity of the care you deliver, or just a generic, copy-pasted template? These EM guidelines are your best tool to ensure your hard work is accurately recognized and fairly rewarded. So go audit-proof your practice starting today. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.